And I happen to be in between the beneficiary side or the implementation side, but also the academia, because sometimes I teach, sometimes I follow on the implementation. So I'll be very brief, maybe mentioning 3 points. Number one is, what have we done best? Second, what can we do better? And third, what are the requests from the community, from the people we are serving? So we've done so well as educators, as researchers, and leaders, politicians, to make sure health, education is prioritized at some extent. That we have new medical schools, we have departments, we have new fellowship programs. But this is very recent, and I don't think it's even expanding at the level we want it to happen. At least we've made a step. On the other side, the demand and the needs have increased significantly. The people are going to hospitals, people need doctors, they're even asking for specialties and subspecialties. When we finished medical school, we didn't know much about fellowships and specialties and subspecialties. Even in my village, the nurse head of a health center was called a doctor. And she was operating and even doing some complex surgeries, because that's the only most educated person who was handling all the needs. She had no other options. But today, the demand has gone up much more than then. And when the demand is there, we have to respond, and we have to connect the demand to the production, the education. So that is at least what we know. Medical education is important. There's no debate about it. The disease burden has increased. There's no debate about it. It's actually changing every single day. We've moved from malaria, HIV, TB, diarrhea, diseases are the main killers. Now we are into non-communicable diseases, cancer, cardiac surgery, and renal diseases, kidney transplants. These are the new things that we're seeing on this continent. The shift is not, it's actually recent, maybe 10 years ago. But it's not just a shift of needs, it's probably the result of living longer, but also of lifestyle, of the exposures that have changed. People have been asking, why do we see more cancer cases and heart diseases than before? But the answer is because before we didn't have time to see these diseases happening. People were dying at 40s, at 50s. Now people are living up to 70s, 80s, 90s. So you have a chance to see those diseases. It's not that they were not there. It's because we couldn't see that happening. People are dying from other causes. So we've managed that. That's another thing we've done so well. In public health, in diagnostics, in tournaments, pediatrics, those were the success of the past. Now, we are looking at a new chapter. Both infectious disease, non-communicable diseases, diseases of wellness, diseases of living longer, and we must shift our strategies, both at the implementation and also at the education side. It's a crossroad. So how do we manage both? Because it's like a double burden for us. How do we work closely together to make this happen? Let's be honest to ourselves. We've worked in silos in some cases. Dr. Paulin has mentioned it, where university, academia, and teaching research were somewhere disconnected from implementation. Are we better now? I don't think so. Not yet. We are close. What is missing? Who should be moving closer to each other? We have all to move. We have to move towards a common goal, because at the end of the day, we are serving the same people, same communities. We're serving ourselves. So what have we done well? It's clear. But there's a lot we have to do better. This is what I want to address. Probably I'll be very direct, reflecting from across, but also from what has been said before. We've had cases, and I'll be using real examples. Some of the universities where you could see clinical doctors and academic doctors. For about maybe 5-10 years ago, you would see a pediatrician who is academic and then a pediatrician who is clinical. These are real cases. The pediatrician will go and teach students in a university, follow them at the hospital, go back at university with the students, and leave the hospital with pediatrician, clinician, and sometimes with a few students there. And one is paid by the university, and another one is paid by the hospital. This is a situation we lived in for about 5 years. And we sat together and said, why do we have academic doctor, pediatrician, and a clinical pediatrician teaching the same students? They're teaching in the same hospital. Then the university is just there for procedures and signing documents and approving degrees at the end. Why don't we teach in the hospital, make the hospital itself as part of the university, as a teaching site? So that is the most recent changes we agreed with the University of Rwanda, let me be precise, that let's not have academic doctors and clinical doctors. Let's have a doctor who is able to do academic work and clinical work. So they use the hospital as a teaching site. Let's transform our hospitals as classrooms, as teaching areas. Because otherwise, at the end of the day, the people you are teaching, they will be spending most of their time in the hospitals. There's no need to go and sit and compete the limited space at the university with other faculties if they can make hospitals the teaching site for university. And at the end, who benefits the most? The community, the patients. So that was one example of disconnection in our practice. There's no way you will be a good doctor if you're not seeing patients. There's no way you will be a good doctor if you're not learning, teaching, reading, using your data while seeing patients to improve academics. That should be applied elsewhere. We should avoid to have academics, clinicians separated. Once you start to see that happening, expect problems. Expect that the Minister of Health will not be connected to the Ministry of Education. And at the end of the day, we all connect to the cabinet. We are one team. And the president will not ask me, what about education, health education alone? The Minister of Education will be with me, explaining how we are improving medical education. It's not an issue of Minister of Education or an issue of Minister of Health. So we are all contributing to one thing. That is one thing we haven't done best. Everyone, every department on fields has the tendency of bringing it in one corner or the other corner. So we should all be in the same team, same place. Clinical academics should be one. It must be one. Is it happening everywhere? You will tell us. You will tell us. And sometimes when you don't create policies and guidelines to address this from the top, to become impossible to change, to become a new culture that will stay for generations and generations. We've seen this even in developed countries. And we are seeing it on this continent. While we build and create new things, we must learn from those kind of practices that were not good, but still happening. Should have the courage to disrupt it. What Phil Cotton was doing was actually these kind of examples. How do we disrupt things, even if we're born and they're there and we saw it? How do we have the courage to disrupt it? So that is the first thing I want to bring to this discussion, that even if we've saw it, even if it's the way it's structured, we should have the courage to change it. Because if we don't, then our children will inherit this, and maybe they will not change it, then their grandchildren will, and so on and so forth. I asked young students recently in medical school how they are learning, how they are reading, things have not changed that much. The medical school we attended, most of the doctors here attend the same medical school. The same size, same classrooms, same library, same tree in front of the faculty. Everything remained the same. In Huye, the medical school is still the same. For me, it's 20 years ago. For others, probably 30 years ago or 40 years ago. Nothing has changed. Same thing. Surprisingly, even the way people are teaching, it did not change that much. Old PowerPoint slides, books or no books. A professor will come and read and teach and leave with some homeworks and go. Slight change, maybe you can search faster, make PowerPoints faster, not the projectors. Remember the plastic projectors. A few things changed, but we can change more, we can change even faster. I don't even think we need to send 300 or 500 young people to sit in Huye or in Butaro or in Kigali to sit for 12 months just reading biochemistry, biophysics, basic anatomy. These are the things that we have with our phones, with our computers. These are the things maybe these young people can read at home. With the internet penetration, with access, maybe you don't need to send everyone to sit there, spend a whole year just waiting someone to drive from Kigali to go and start introduction on biophysics, introduction on anatomy or physics. Maybe you can learn better. Maybe you can access a professor sitting in Barcelona or in Boston or in Paris, teaching our young people at home on their villages without spending a lot of money. Does this change the quality of education, or it improves even the quality of education? Because if you see the most time these students spend in those universities, it's all about logistics, cafeteria, eating, coming back. Maybe they need half of that time together, another half reading from the distance. Maybe this artificial intelligence, the AI algorithms can help even to summarize and teach better. This is another area I think we need to be humble enough and accept that the world is changing and we must adapt and change, even if we don't agree 100%, at least agree that there are new ways of doing things. In academia, probably is an area where change takes time, and is going to be in the resolution of this meeting, hopefully. And you're going to say, let's wait for the next academic senate in the next 6 months to discuss this and to review it, or next year. Again, that is another level of bureaucracy that we need to change. And if something has to change today, why do we push it to a Senate academic meeting of next year? That's another way, another challenge to address, to embrace. But otherwise, coming as deans, as partners to a meeting that will result to the same practices will be good for coming together. But what we need now is change. That's what I heard from previous speakers. We need change, we need a big change, because the needs are there. The needs are there, the diseases are changing, but the way we address or design our teaching programs is probably not connected exactly to what is out there. Last week I went to Northern Province for an outreach program, and we visited a hospital called Ngarama Hospital. Sorry, Gatonde, next to Ngarama. They are close to each other. We spoke to the community, asked, what are the main reason you came here? There were so many that came for military medical outreach programs that we were conducting together. And they said, actually, more than half, they were there for dental problems, for oral diseases. Then we discussed with the people at the University of Rwanda and other faculty who attended the same event. Do we have the same design of our education program addressed to the needs in the community? The answer was no. We don't have a focus on dental or oral disease program or tracks of education. Yet this is the main problem we have in the community. Actually, it's very rare to have a dentist or a dental therapist in our hospitals and our health facilities. On the other side, you have maybe faculties more into, I'll use other examples without any target, maybe political science, history, gender, rural management, or water. These are important, but these communities need dental care, prevention of dental problems, dental care, than other priorities that we are putting forward, maybe because it's easy to teach, maybe because it's convenient for the universities, for academia to establish, it's faster. So if we have to solve the problems in the community, let's start with the community and ask what are the issues we have, how we go back and design solutions. In medical education, it's even urgent. If you had more road accidents and you don't have importance in training of neurosurgery in surgical fields, you're not addressing the problems. If you have maternal problems, maternal mortality, C-section challenges, you're not training that, you're not addressing the real problems. So before we create new faculty or fellowships or residence programs, let's go back and say, what are the most important, the most needed fields of this area that we're going to address in education, in research? Then we'll help implementation to happen. How does the Ministry of Education and Health brings all these actors together to design these programs? If you're not having that conversation, at least read, use data, and say at Senate, before we approve any new program or training, let's look at the statistics. Do we need to start residence for pediatrics or residence program for surgery? Within surgery, which one do we need to give high importance and why? Is it informed by evidence or not? What about the next 10 years? With technology, the role of AI, is it going to solve the challenges we have in imaging, in pathology? Or AI has a limitation in some fields. They are the ones we're going to design differently. Some areas will be extensively supported by technology, by AI, like pediatrics, like town medicine, like maybe other areas not. Like hands-on, you need to be there. AI is going to help to do it better. Like the telesurgery, robotic surgery. Some areas maybe AI is going to take 9% of the burden of the work, like imaging. We're seeing it happening. How do we embrace it without pushing it back? Because the more we push it back, it's going to come back with more speed. Actually, you can't resist it to happen. The young people are already pushing it. Let's accept it, integrate it, embrace it, facilitate it. Last point is on research. Research must be transformed, must change as well. Research should not be just with the aim of publication. Research should be there to solve problems, should be there to train people on how to think, how to address issues in the communities. Research should not be there just to promote ourselves within universities. The money spent on those kind of research is the money lost. So changing research, make it a tool for solutions, a tool for education, a tool for thinking and teaching, should be the research we support. Research should not start when you're already a professor or an associate professor. It should start when you're a student, at the early years of education, so that you start thinking and even trying and testing with that energy. Because the more you grow, the more you think differently and even sometimes limit yourself into risks. And research is about taking some risks, calculated risks, sometimes crazy questions that will become a new standard in the future. So young people are better at that than those who are already achieved a lot in their career. So let's change research, let's transform it. Especially on this continent, there's a lot of questions that are not answered. It should be done by the people who are facing those problems. This morning I was listening one radio talking about a conference in South Africa. Some doctors were giving feedback about researchers who are flying in and collect data and go back. The conference about genomics, human genome in particular. And there are a lot of complaints about senior researchers just flying to collect information and go use the data to design new tools, new medicine, but nothing is left in the community. That should not be accepted. There should be also equity in research. There should be respect to the communities where this data is collected. And if you collect data and you leave the community in the same problems that they had before you go back to collect the data, then you're just stealing, and that can't last longer. So that also must change. It must change from the way we conduct research. It should be for capacity building, for solution making, also transforming these people's lives. It could be small, it could be just small. Telling people, your water is not clean, there's heavy metals in this water, and it has to be addressed. To me, that is much better than a clinical trial, heavy new drugs that you'll never get the drug landing in that community. So that is another reflection that we need to bring in this type of conferences and meetings. Let me conclude by saying these are just reflections from what you said, that I believe and strongly support that if we continue to work together through the consortiums, the universities working together, not competing to each other, that we train young people who are going to solve problems, not just their own titles and affiliations. That is the reason why we should always be coming together as researchers, deans, policymakers, students, and also community representatives. Can it be achieved? 100% yes. We are even better positioned to achieve it with the power of technology, with the tools we have. We can even catch up with the legacy that we accumulated, especially on this continent. We can have more people trained, and training more doesn't mean you lose the quality. So you can even train less with low quality. Imagine that disaster. And imagine that opportunity to train more with the highest standard. And this is what we are aiming for. And that is what we've started to do in Rwanda with the support of several partners, universities, to form what we call 4x4 strategy. It means we are quadrupling the numbers of the healthcare workers we have, especially in the medical field. 4 times, because that's the minimum. All African countries, almost all African countries, are below the minimum. Below the minimum. We are not even at baseline. So at least 4 times we reach the minimum, then we can start to run faster without concern about our health system at risk to collapse because there are too many patients and no doctors. So uplifting the quality, the quantity together is possible, especially when you add technology, you add partnerships, and you spend less. You just need one thing: the courage to do it. And I can see that there is courage in this room. There is empathy. There is commitment. There's always questions that maybe what Saben is talking about is not possible. Or he's just dreaming. But we've seen from the history that when you want to transform something, there is always a big number of people who say it's impossible. Always. When everyone comes and say, yeah, let's do it, and we can do it, most of the time, that objective, that goal, is too small and too easy to understand by everyone. When it's too big and too transformational, there's always a big number who say no. But there's a small number that will always say yes. Let's stick on it, let's obsess it, and let's do it. And those are the people in the history who have changed, who have created these new standards we are living in. We need those few people who believe that we need to train more people in medical education, train them well with the highest standards, and embrace technology as fast as possible, and obsess it and achieve it until we come back here and say, we said it in 2025, now we are back and it has been achieved. So, ladies and gentlemen, thank you so much